honestly, realistically, the medical community has failed women. There's a huge culture shift now that patients aren't taking it anymore. So now that people can say, oh, wait, I'm not actually getting the standard of care. It's those stories, it's those voices, it's podcasts and platforms like this that's going to help change and shift this narrative of neglecting women.
Welcome to Fempower Health. Georgie here. Out of all the episodes that I have done on menopause, this is the one that we need to be most proactive about, because if we aren't proactive, it is what can create those negative stories we tend to hear about the suffering that women have in menopause. Now, quick clarification here. Menopause is not just for those in their 40s and 50s and above. It can happen if you are on medications for endometriosis that can induce menopause. It can be chemotherapy, and it can also be right after you've delivered a baby. So this Genitourinary Syndrome of Menopause, which is a mouthful called GSM, it is essentially defined as a collection of symptoms and signs that are caused by this hypoestrogenic change in our bodies. And what's really important context to understand is a lot of times, we say, hey, we're going to our annual physical, seeing our OBGYN, but a lot of that tends to be pap smears. But do we ever ask our OBGYNs to inspect our vulva? And even if we did, were they properly trained? Because according to my next guest, Dr. Maria Uloko, who is a urologist and specializes in sexual medicine for all, she will tell you a little bit of the truth on what really goes on with the training. And let's face it, are you inspecting your vulva so that you can inform your healthcare practitioner what might be going on down there? So whether you are a clinician listening or a patient who is looking for answers, please listen to this entire episode. Dr. Uloko is so wonderful and such a huge advocate for getting the right information out there to us. So thank you so much for your time. And let's dive right into the episode. So, Dr. Uloko, it is so nice to have you on the Fempower Health podcast. I had the pleasure of meeting you at the Let's Talk Menopause Summit in New York City in March. And it was an exciting time because I had never met Rachel Rubin, who is a colleague of yours, and the two of you work so closely together. And I had interviewed her not that long ago, actually, about orgasm. And I love her because she is I don't mess around with health information kind of person. And I noticed on the panel that you are just like that. So of course, I had to have you on the Fempower Health podcast because those are just the types of guests I like to have, because it's so important for the practitioners that listen, as well as the women who listen, to really get the information that's so hard to find. So thank you for making time. You mentioned you're at a urology conference. So you really put in the effort. So an A++ for that. So thank you so much. So before we dive into this really important and often misunderstood topic of genitourinary syndrome of menopause, why don't you tell us about yourself?
Thank you so much for that amazing introduction. So my name is Dr. Maria Uloko. I am an assistant clinical professor at the University of California, San Diego. I am a urologist that's specialized in comprehensive sexual health, which means that I take care of the medical and surgical care for all genders and when it comes to sexuality and sexual health. I'm also the director of the Vulvar Sexual Medicine Center at the University of California, San Diego as well. And so I am a very passionate advocate for closing the barriers and closing the gaps in research, access, education, and treatment and diagnosis for my patients when it comes to the different sexes, because it's very clear, being able to treat all genders and all sexes, that there is a huge disparity in people's ability to access care, people's ability to get care, and then the research that we're doing as well. I'm also a researcher, so I do a lot of research work, and again, with the goal of increasing access and debunking myths, because that's a lot of sexual medicine especially when it comes to women's health.
No, absolutely. And it's funny, I'm so glad I wrote this quote down because it's a relevant transition to exactly what you just said. And I think it was Dr. Rubin that stated this at that summit. And she said, urology is the triangle of what genitals do you have, which do you want, and how do you want them to work?
That's a perfect analogy. Yeah, I am a big believer that, our understanding of the gender binary and all of these things has actually really been detrimental to our overall care, and just kind of thinking about genitals as exactly that. What what do you have? What do you want? And then how can we optimize that? Is really been a huge metric is in terms of how I can deliver care and how I think about research.
The other piece too, and I think this is an important thing to bring up, and then we can dive into genitourinary syndrome of menopause, the role of urologists. So I have to say, I had always thought urologists were for men. And I always wondered, especially as I've been doing the podcast, where do women go? Like, is it just the GYN? And then what happens after that? And it's so not the case. Clearly, even with the work that you and Dr. Rubin are doing, I think you guys are even, which is probably why you're part of the many reasons why you're at this conference, is you're on your own going to these conferences to educate urologists on cis female anatomy because of
Yeah.
these challenges. So tell us about that dynamic, because I think what's really interesting to me is not only is it the lack of research in women's health, but it's even the way training works that impacts the treatment that women get, the diagnosis, et cetera. And I always like to give that kind of a perspective, because I know a lot of people come into this podcast just really irritated that they can't get answers. And I think that context, and then diving into what genitourinary syndrome is, and how to navigate that, is so important. So talk to us about this whole lack of understanding amongst the urology committee and how that impacts women with genitourinary syndrome, and many other factors.
Yeah, so I mean, it's actually a really unique thing, and it's actually really, and by unique, it's a long and storied history, and there's so many factors that go into it. I think the first question I'm going to answer is, the misconception that urologists are just men. It's a misconception that's based on a lot of facts, because there are, I mean,
Yes.
as it stands right now, I think the split of urologists is like 93 or 94% men, 6% women. There's more trainees going into the field that are that are women, so that curve is, it's going to get better. But when we think about what a urologist does, they are the surgeons for the genitourinary system. So that means the kidneys, bladders, anything related to urination, and for the most part, male sexual health. But the thing is that there are a lot of female sexual health conditions that actually directly impact the bladder and people's urination. And it's really fascinating if we kind of just look back at the history of gynecology and just kind of its really storied, kind of murky history, in the context and the social and historical context of how that field was developed. It was developed oftentimes with the principles that, women didn't deserve quality of life, right? It was more so birthing and how can we get babies out so that we can then increase our line, and hopefully it's a male baby, and that whole storied history. And so, because of that, that oftentimes vulvar sexual health has actually fallen out of the wayside. OB-GYN and gynecology, the fields respectively, have not done really great jobs in terms of owning women's sexual health. And so it's actually a unique thing of what Dr. Rubin and I are trying to do, and also many other urologists are also trying to do, is increase the participation of other urologists and train and teach and educate about vulvar sexual health and just sexual health in general, because it's actually a really, really poorly taught, really poorly executed means by the medical community, if we are just being really frank and honest. And that directly relates to patients having really challenging times getting care and access to care. I mean, there's so many statistics just to get common diagnoses and get common treatments. And there is so much misunderstanding that, the vulva and women's sexual health is just gynecology, but when in actuality, a lot of the advances in sexual health and vulvar sexual health has actually been urologists. So Dr. Helen O'Connell was the first person to ever fully define the 3D structure of the clitoris. using MRI, and that was back in 2005, I believe. And me and my colleagues, Paige Isabey and Dr. Blair Peters, were the first to actually define how many nerves are in the, or axons are within the human clitoris. So these are things that are happening by urologists. And I think our overall goal is that we combine with gynecologists and internal medicine and dermatologists, because these are professions that people are going to get sexual health care. And so we're trying to come at this from a collaborative standpoint where we're educating the masses, teaching, getting people involved, getting people into research. And, I mean, honestly, realistically, the medical community has failed women historically. And, I think there's a huge culture shift now that patients aren't taking it anymore. There are things like podcasts, there are things like social media. It's actually been a really great thing, a talking point for social media. So now that people can say, oh, wait, I'm not actually getting the standard of care, or the standard of care isn't good, we could be doing better. And it's those stories, it's those voices, it's podcasts and platforms like this that's going to help change and shift this narrative of neglecting women and the medical gaslighting of very common conditions that we just as a medical community have not actually prioritized.
Absolutely. Well, thank you for speaking the truth. And honestly, having clinicians question the way healthcare works it brings credibility to the challenge. So now let's talk about genitourinary syndrome. So I'd love to define what it is, and we'll talk about lots of solutions, et cetera. But again, I think it's important to understand it, but then figure out how women navigate through it given the reality of our healthcare situation. And I also want to make sure, because I would assume right now we're focusing on cis female. And if there's anything you want to add nuance wise that is relevant, please share, because that is not my area of expertise. But yes, please define.
So genitourinary syndrome of menopause, I think or GSM is what it's called, is a very common thing, and it's due to the loss of hormones. So I tell people that if you do not have healthy hormones, you cannot have a healthy vulva. If you do not have a healthy vulva, you can then not have a healthy bladder. That statement kind of sums up what GSM is. And so it is when menopause happened, essentially your body stops producing kind of the big hormones, estrogen, progesterone, and then most of your testosterone production is also gone, but you do still produce a small amount. I'm going to use the worst analogy ever. I'm so sorry, I apologize, but this is the one that makes the most sense.
No problem.
Your vulva is a garden, but it actually makes sense. So without hormones, you cannot then water the garden, right? And so without hormones, you cannot then keep your vulva healthy. And then what happens is that there are actual physical changes to the vulva that then result in symptoms. So physical changes are literally the vulva starts to close shut. And these oftentimes are really silent changes. And the reason that they're silent is because most of them, when they begin happening, they're asymptomatic, but also a lot of people aren't looking. So if you were to look, you would notice these changes, but people don't notice it until they start having the symptoms. And so the vulva literally shuts down. The skin of the vulva becomes red, raw, and inflamed, which then translates to the symptoms of urinary urgency, frequency, frequent UTIs, frequent yeast infections, pain with sex, decreased lubrication, decreased vaginal infections. So those are the big things associated with GSM. And that's why I use the garden analogy, because it makes sense. If you do not water your garden,
Right.
your garden cannot thrive. And then all of the other things start to happen.
Right. Understanding these symptoms, this is really about, there are ways to prevent some of these things that can happen due to age, and this is not about, oh, our life is over, menopause is the worst. Because I can I just say this, I am so happy people are talking about menopause. I sometimes feel like the tone is still like, oh my God, this totally sucks. And it's driving me a little bit crazy. And I'm not at all minimizing the challenge. I mean, this is funny. So I thought I was in menopause. I thought I was postmenopausal. And
Uh-huh.
5 months in, I go to Sedona. And day 2, after I went to the birthing cave, I know this sounds woo-woo, but it's actually just kind of funny, the timing. So the after I finished my hike to the birthing cave, I come home and shoo, it comes back. I'm like,
Just like that.
like, are you kidding? So, but nonetheless, tell me your thoughts since you have the experience in working with so many patients and are medical doctor. How should we really, I mean, is this scary? Is this just a natural part of life? Like, what is this whole like, oh, let's get in this corral of this sucks. I'm like, let's be
Yeah, yeah,
positive.
yeah.
There are solutions here.
Yes, yeah. So it's actually so fascinating. I don't think I would have thought about menopause until I started being a menopause provider. And I realized, yeah, like it's so interesting because now that I know that there are solutions, I'm like aging, I'm fine. I'm like excited to get to 70, right? Like I don't think once you hit a certain age, your life is over. You know, one of the things is that humans didn't used to live as long as they did, and now that we're living longer, how can we then support their quality of life? Big believer in quality of life. And I think with appropriate menopause management and care, we can maintain people's quality of life. Like one of the biggest complaints I always get is I just don't feel like myself. People just want to feel like themselves again. And the easiest thing and the way to get to that is with hormone. I mean, with hormones, I'm a big believer in hormone replacement therapy. I know there's just people up on both sides, but I really do think it's a safe and effective way. And as a urologist, it's also really interesting because I get to be at this unique standpoint where I literally get to see the differences in care between sexes. So when men go through menopause, they also have low hormones, and you can't watch a sporting game without hearing about low T, da 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 da, all the symptoms of low T, and like it's actually celebrated. We celebrate that they get their quality of life back. I love being able to support my male patients through their transitioning, and I think it's just wild that there's such conversation and such should women be allowed to age gracefully and keep their quality of life. I'm like, why are we having this discussion? Why aren't we doing more conversations about how can we make sure that we are centering their quality of life? And why aren't we doing clinical trials? Why are we still having conversations about like a really poorly analyzed and interpreted study about hormones? We're still talking about, are they safe? I'm like, in urology, we are like, our patients deserve a quality of life. We care so much about their quality of life. We're like, oh, well, testosterone and men with heart attacks, that could potentially be dangerous. We're like, well, but they also need it. So let's do a clinical trial and see if it's safe. That would never get done in the world of women's health. And I'm realizing this, and I get to specifically see it because I'm standing at this precipice of being able to treat everyone, and I get to see the indirect how there's such a difference. And with that, I tell people, you do not have to suffer through menopause. There are options, there are treatments. You can still live a great life. Like will be doing this until forever, because I can, because I know that there are options and I am privy to that information because, I get to do the research, I get to do those things. But that's why I'm screaming out at patients and like telling people, tell your girlfriends, tell your mom, tell your sister, tell anyone that you know that you do not have to suffer through this.
Yes.
Like there's this really cultural norm that women just suffer or they're difficult or they're this, and it's like, no, we as a medical community are doing a bad job of providing good care. And then two, there's a lot of fear mongering that is happening, which is also then preventing people from getting the right care. And then three, this is all easy things that we can be doing. It just has to take an individualized approach.
Let's talk about, so there's two things. One is how to be proactive, but two, discussing these hormone therapies. Maybe you could just expand on that.
Yeah, yeah. So the WHI study, it was a study to actually test the safety of HRT, because HRT became really all the rage in the 60s, 70s from the European market. They were doing it over Europe, and so we brought it over to the United States in the 60s and 70s. So a lot of people were actually getting through menopause with support. But then the question was it safe? We knew it was effective, but was it safe? And that was one of the things that study was meant to do, was to test the efficacy, but then also the safety of it. The hard part is that when they enrolled the study, or like when they enrolled for the study, they actually had to stop the study early because there was a higher incidence of cardiac events than they wanted. And so that little blurb then took off like like wildfire. That then translated into hormone replacement therapy is dangerous. Do not use it. And so I think the statistic was 60 to 60-ish percentage of doctors felt comfortable providing hormone replacement therapy prior to the WHI study. And now it's down to like an abysmal 10%. And really the fascinating thing about that study, if you actually look at the data, because that's the other interesting thing is that a lot of doctors will just poo poo and say hormones are dangerous. And I'm like, look at the study. The study actually showed that the average age of the patients were 75. So that's about almost 30 years past menopause. Like, why are starting of perimenopausal symptoms or menopause? Like, if you give 75-year-old anything, they're probably going to have an adverse event. Like, it doesn't make any sense. So then they did actual analyses of, they broke it down into age. Okay, they're like, okay, well, 75 is a little too old. So let's actually break it down into age. And they actually found that if you were less than 60 or within 10 years of starting menopause, that's when you saw all of the health benefits. So they actually decreased colon cancer, decreased rates of endometrial cancer, decreased rates of fractures, decreased rates of cardiac events. So it's actually safe for your heart, it's good for your body, and then also the quality of life factors. Menopause symptoms are detrimental to quality of life, can be detrimental to quality of life. Not everyone has these severe symptoms, but for those that do, I mean, I don't have to tell them twice that it sucks. And so the study, it's there, the data is right there that actually shows that hormone replacement therapy is safe and effective and actually beneficial long term. And yet there's still this weird disconnect in medicine where they're like, it's not safe. I'm like, yeah, but the data doesn't show that. It's, again, there's this weird underlying thing that I've noticed when it comes to women's health, that we don't look at data and instead go straight to dogma and paternalism of telling women what they should be doing and saying it's too dangerous, you can't have this, versus having shared decision making, using data, using logic, and letting people actually make decisions for themselves.
Absolutely. Now, let's put into context those, for example, that have the certain gene for breast cancer risk. So, can we talk about that as well? And then we can get into which hormones, when do you take them, and the impact, all that stuff. So tell us about those with certain gene for breast cancer risk and other possible cancers.
Yeah, and so what we're talking right now is about systemic
Yes.
hormones. And so the treatment for GSM is actually local hormones. And so when we think about the link between people with increased risk of breast cancer and systemic hormones, that is a question that actually hasn't even been fully answered yet, right? Like, we as of right now, the guidelines state that those are people that shouldn't be getting systemic hormones. In terms of local hormones, those there's been no there's been more evidence showing that it is safe to take local hormones. So that when we say local, we mean vaginal or vulvar hormones. In and that has to be, again, a shared decision making between patients of whether or not you want to take systemic hormones, because it's all about quality of life. Let's say that yes, you do have an increased risk of breast cancer, and there's no poo-pooing the significant effect of a cancer diagnosis on anyone. Like, there's just no way around it. It's devastating. But there is also, we also have to think about probability and likelihood and all of these things. And thinking about your quality of life is like, there are non-hormonal options that for some people will start and try if they do have a positive family history. But for those that aren't working, there is the options of hormones, but it has to be a really dedicated discussion with them, understanding the risks, understanding their benefits, and then giving them the opportunity to make that decision for themselves. Understanding what their quality, like I always ask my patients, what is your goal? Because I'm now going to give you your options now that I know your goals, and you have the ability to make that decision for yourself. I'm not going to make any decision for you. You have to do that. And I think a lot of women don't get that choice. They do not get even the ability to say, to ever be given that option. But in terms of just like the general population, or the general feeling towards people with a higher incidence of breast cancer risk, with a known genetic risk, we try to steer away from those hormones solely because we don't have the data to show what that looks like. And that's where we are. We're just not anywhere near that. We're still having conversations of nuanced conversations of anyone with any risk. Their hormones are scary. Like that's where we're still
I
at in this
know.
general landscape of women's health.
It's really frustrating. Now, for the absorption, because I remember clearly at the conference, there was discussion around not the systemic hormone, because again, the conference also was focused on genitourinary syndrome of menopause, but for the localized hormones, what is the absorption rate? I think there was a comparison of taking 2 birth control pills in a year or
Yep.
something to that effect.
Yep.
Like it's so
Yeah.
minimal. So can you talk to us about
It's
that?
it's so minimal. Yeah. So it is, yeah, there have been studies that have been done that actually looked at what the systemic absorption is. Because, we say that although it's local, that you don't get a lot of systemic absorption. Like, what if you do? Because hormones, this is the interesting thing about hormones is that no matter what the data shows, how each person's body reacts to hormones is very
That's true.
unique. And so again, it's a very individualized process, even when it's systemic versus local, but local tends to have less of the systemic things. So there is that fear of that systemic absorption. Oh my gosh, I put really low dose estrogen into my vagina. Am I going to get breast cancer? It's like, no, like, no, it's the same equivalent as, like you said, taking 2 birth control pills. The other fascinating thing too, that doesn't make sense to me as a researcher is, if we actually look at the data of who's getting breast cancer, most of the people getting breast cancer are actually postmenopausal that haven't taken hormones. They're postmenopausal, they have no estrogen on board, and yet they're still developing breast cancer. And so I think there is this there's this misconception that estrogen causes breast cancer. No. And I use this in the analogy of prostate cancer. So as a urologist, I know how to treat prostate cancer, and I used to do a lot of prostate cancer research. But if we look at prostate cancer, so again, another disease of older people, but younger people can get it, but the average age is usually in their 60s, 70s. Same with breast cancer. Those people are oftentimes have low testosterone at baseline, just again, the natural aging process. And yet those are the people that are getting prostate cancer. In our understanding, in our knowledge, we know that those people are going to get prostate cancer anyways. We just know that the prostate cancer is then fed by testosterone. We're not saying that testosterone causes prostate cancer. It's just something that happens, and we're still working on that, on the science behind it. But in our heads, we don't think, oh, testosterone causes prostate cancer, because then we castrate every man, right? And that sounds ridiculous, but that's actually what we're doing to women. We're allowing this castration or lack of hormones to happen when they don't need to happen, and we see the suffering happening. And in prostate cancer, we know that it's not caused by testosterone, but we know that if testosterone's on board while you're actively treating it, probably isn't going to help the outcome. So we actually treat the cancer. Once the cancer is treated and it's eradicated, we actually then put patients back on testosterone. I could never do that with my female patients. And yes, there is biologic differences between the cancers, but breast cancer and prostate cancer are actually very similar biologically. And I wish that we had the same treatment modality, or like the same kind of push of how can we increase the quality of life for these patients? Like, yes, we're saving their lives, but like, why aren't we then trying to improve the quality of their lives? It's oftentimes because we don't think of that additional step of like, but how are they actually living? What is their sexual health like? We don't think about that when it comes to women. It's very fascinating. There were numerous studies about post-cancer treatment and the lack of care in terms of sexual health.
So then let's get to the reality. Okay. So women who are in menopause, and by the way, let's clarify, this is not just the 50-ish year old woman. This is also someone who's had a hysterectomy, correct?
Mm-hmm.
And what about patients who are undergoing certain cancer treatments, they may also, because I remember my mother, she had non-small cell lung cancer. And I remember after she was done with her chemo, her period came back. And I just remember that being like a big celebration. And so I assume there's like a lot of reasons why a woman would be put into this state of menopause. So
Hmm.
it's essentially any of these women, not just the ones who are hitting the 50-ish age, correct? That is who we're
Yeah,
talking about. Okay,
yeah.
just want to make sure.
Yep. Anything that can have any sort of effect on your hormone
Hmm.
production or effect on your ovaries or adrenal glands can cause GSM.
Okay,
Again, using that analogy of water to the
okay.
garden. Without the water, that garden cannot thrive. And so the water is hormones. And if you don't have the hormones on board for whatever reason, whether it's breastfeeding women actually get GSM symptoms because when you breastfeed, it actually shuts down your ovulation, and so you do not produce hormones like you normally would. People getting treated for endometriosis, we're shutting down your ovarian production of hormones because we think that's considered. So a lot of people will actually develop GSM, and GSM is again the urinary symptoms and then also the sexual pain symptoms or can and yeah, it's a very common thing. And the longer that you don't have hormones, the more progressive these changes are.
Everyone who has this loss of hormones needs to be proactive.
Yes, yes. So that is my big push. So I'm a big believer in prevention instead of intervention. There are so many women I see that are 90 something years old and their vulvas are itchy, red, raw, crying, sobbing, and they're essentially the opening is like almost sealed shut because no one did the same preventative care that we did for the rest of your body, your mammograms, your colonoscopies. Like, why are we not also prioritizing vulvar health? Because vulvar health is not just sex, it's actually urinary health too. And so many people die from bladder infections. It's actually killing people that we are not prioritizing vulvar health. And I say this to everyone, the vulva that I like, not mine, the vulva that you have pre menopause should be the same vulva that you had on your deathbed. There's no reason that we should just accept that people's vulvas will just shrink and shrivel up. There's no reason, like, and yet we've widely accepted it. It's just, oh, it's a natural part of aging, da da da. It's not well, it's a natural part, but just because it's natural doesn't mean that it's
Okay.
acceptable. And so, and there's, especially when there's a a proven safe, low cost option to prevent all of these issues down the road, like, I want to scream it from the mountaintops. Like, every person that's 35 and up, start looking at your vulva. I mean, anyone actually, look at your vulva, check your vulva, make sure that you are looking and understanding and looking for these silent changes because the symptoms happen much later before the actual physical changes start. And so once you start seeing these changes, things are just not looking like they should. Go into your doctor, start advocating for yourself and being like, I want to be on hormones. Like, because you can, that's the other thing I like to tell people is that, or vaginal hormones. I like to tell my patients that they are their biggest advocate in the healthcare system. As a Black woman in healthcare, and as I've had my own personal experiences with the healthcare system, as someone that is health literate and has, like, all of the connections, I still have been mistreated by the healthcare system. I can't imagine what people that don't have the same privileges that I do. And so I tell them, you are your biggest advocate. You can advocate for yourself. There's like, your doctor knows something and they mean well, but a lot of them aren't staying up to date on the literature, aren't staying up to date on what you need, or have their own unique biases or fears. And you get to advocate for yourself. They don't always know everything, and not challenging them per se, but also just saying, like, no, I also did my research, and having discussions. I think the doctor patient relationship should be more so a discussion of, here's what the data shows, and you get to make your own
Right.
decision.
Okay, I agree. Something also so interesting is you guys mentioned this is not about going and getting a pap smear. This is going and getting your vulva examined by your doctor. But, like, as you said, we're with our bodies every day. We should also be examining it because I would assume, as a good patient, we go to our doctor and hopefully we'll say, hey, I've been inspecting my vulva and I'm noticing blah, 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 right? That's what we should be doing as a patient so that the doctor can then do something. So tell us about this experience of how we as the patient can be more empowered, but then for the clinicians who are listening, what can clinicians do better by their patients in this whole
Yes.
dynamic?
Yes. Clinicians, what we can be doing is taking a proactive stance to um, vulvar health and vulvar care. And like I said, I've mentioned several times, you cannot keep that garden healthy without hormones. So we should be in our clinics as urologists. We're seeing a ton of patients with recurrent UTIs. And that's one of the symptoms of GSM. And in our arsenal, we should also be saying, you have to take this medication. Like there's no I mean, you don't have to, but these are the reasons why it's helpful. So a lot of people will, what I think I've noticed is that a lot of people will get prescribed vaginal estrogen, but then won't take it because they don't know why. Like it's because they're like it's a mess, it's a whole thing, and I actually have to use either the analogy of the garden or I use this other analogy, which I think is great, is let me say that I was going to, like, all you had to do every single day, like, take a look at your leg. What if I told you that if you were to put lotion on it, once every day for 2 weeks and then just 3 times per week, um, it would then shrivel up, become super painful, red, raw, cracked, and irritated. Would you put the lotion on or would you just let your legs shrivel up and get infected and all these things? And yeah, maybe you're not a marathon runner, but would you let that happen? And they're like, oh God, no. and and then I'm like, that's what you're letting happen to your vulva, right? Like, and that analogy actually makes sense to them because no one actually explained to them why they're doing anything. And they're like, yeah, it's just a cream. I don't know. I mean, there's so many times we haven't done our face routine, just because we're like, oh, whatever. It's like the long list of things. But if you actually understand, like, oh, this is a health benefit, I am preventing a lot of things. I'm going to definitely take their vaginal hormones. Um, so that's one thing that providers can be doing is feeling comfortable prescribing it and then explaining to people why they're taking it and understanding that. And then from a patient standpoint is getting comfortable with their bodies. That is something that I was really surprised by. Every time I examine someone, when I examine my male patients, they're like, "Yep, whatever, just go for it." Obviously there's a little bit of that interesting, unique difference because I'm a woman and they're a man, but for the most part, there's really not. It's not uncomfortable. Versus when I examine every single woman, they say, I am so sorry. I apologize. I'm like, for what? We haven't even started. Like, what are you? Every single patient I have has always apologized for their bodies. And that tells me that there is a social cultural shame that is happening around women's genitalia and vulvar genitalia, right? Like that is so unique. No one would apologize if their elbow was broken or hurt or injured. You don't apologize to your orthopedic surgeon about your hip or your knee. But when it comes to the doing a vulvar exam, so many people apologize. So there's so much shame. People have been told that their bodies are not good or, that it's not a clean area or they should be disgusted by it. They shouldn't. They should actually look at it. It's a body part. It's an important body part and it's not just for sex. You can also urinate. And so many people are like, well, I'm not having sex, so I'm not going to take my estrogen. And I'm like, you have all the other organs down there too, like your bladder. And so that's a fascinating thing. And so the other thing I tell people, or the distinction between so as a vulvar specialist, I do things very different than a gynecologist. Not super different, but I spend a lot more time on the external. I don't do pap smears. That's not within my scope of practice. I spend all of my time on the external, and because there are way more structures externally than there are internally. There's the vagina, and then there's the cervix and the uterus, period. Versus there's the clitoris, the mons, the mons pubis, the labia majora, the labia minora, the vestibule, your pelvic floor muscles. These are all on the outside, and a lot of times these are completely disregarded in the standard gynecologic exam. Like that's just how it's taught. They are not taught how to look at the external structures. Like that's one of my big pushes and research focuses is how can we change how we teach anatomy even to medical students, because medical students don't know this. Urology residents, gynecology residents, you go through your entire training without learning about how to examine the vulva. You learn how to put a speculum in, you learn how to look at the uterus and the cervix. That's about it. You don't actually learn about all the other structures, which is such a detriment and is a direct result as to why so many people are still dying of UTIs, getting GSM. We need to be doing better from a medical standpoint of being proactive, and then also and explaining to our patients why they need these things, and then also from a patient standpoint of advocating for yourself. That looks like looking at my vulva. That looks like getting comfortable with anatomy. And yeah, it's a big task and it's a big push, but I'm excited for
That's
it.
awesome. The hormone you're talking about in this case is vaginal estrogen.
Yes. It's vaginal estrogen. Estrogen is very important for the overall vulvar health, but so my research focus is the importance of testosterone as well. There are numerous studies that have mapped out the testosterone receptors in the vulva itself. There's still more research that needs to be done as to what is the full role of testosterone, and that's the research I'm obsessed with, because there are a lot of pain conditions that are not actually an estrogen issue; they're a testosterone issue as well. And so, that data still needs to be elicited or elucidated out, and that's like I'm really excited for some upcoming data coming out. But so yes, mostly just vaginal estrogen. There is a role for vaginal DHEA, which then is converted to estrogen and testosterone. But this is just where we're at, like in the landscape of research in vulvar health, is that we still haven't fully mapped out the vulva. Like we just came up with the nerves, like back in October. We're doing more work and more research to fully map this out because it's all going to translate into clinical care.
Wow. So, and the reason why I had asked about the vaginal estrogen is I do remember also at the conference you talking so much about testosterone, and I wanted to make sure we're very clear in delineating, because I did want to also make sure we brought up some of the great points you made about testosterone. So, a couple things I wanted you to elaborate on is, based on what we know today, what would the role of testosterone be? Number two, the precautions. So I remember some folks talking about hormone clinics, and as we know, Manhattanites, Manhattan is the place where all the innovative, different ways of practicing tends to start, right? And apparently there is lots of hormone clinics, and there was a lot of precaution around that, as well as the hormone pellets. And so I wanted you to kind of expand on the testosterone piece of this, of the why, and then the precautions.
So when I'm thinking about when I talk about hormones, I'm thinking again we're focusing on the vaginal hormones.
Yes.
So in terms of what I can tell you, there is a medication called prasterone, which is vaginal DHEA that is then converted to estrogen and testosterone within the vaginal wall. And that's used as a treatment for dyspareunia or pain with sex. I think the big research question that I still want to answer is, should everyone be on vaginal estrogen and testosterone? Because it is part of, again, it's part of your physiology and your anatomy. Like, let's replace what has been lost. And then because there are certain people that vaginal estrogen alone isn't enough. And there are certain people that vaginal estrogen alone is perfect. And there is actually a little nuance, because you still do make a little bit of testosterone. And for some people, that's enough. And for some people, that isn't enough. And so this is my brain. It's all constantly just thinking about research questions.
I'm totally tracking, because this is how my brain works too. So I'm right there with you.
Okay, good. And so, yeah, you do see these nuances of people just on estrogen and vaginal estrogen, and they feel great. Everything's awesome, no pain, da, da, da. And so I love this work because there's so much research to be done. And I think instead of looking at it as, the end all be all, like it's just like, oh, that's another clinical question that we can answer. But what we do have right now is vaginal estrogen and then vaginal DHEA. In terms of systemic testosterone, that there are actually multiple guidelines that actually endorse the use of systemic testosterone in women, that postmenopausal women with low libido.
Okay.
So there are multiple guidelines. There's not really much controversy surrounding that. The controversy that is there is when we this is the other interesting thing, is medicalizing and medicine and capitalism. This is where it just goes to shit, because it is kind of this like nuance, or it's like this like poo-poo thing. We've always thought about testosterone being a male's hormone, but it's actually an every person hormone. And we know that people benefit from testosterone. Postmenopausal people benefit from testosterone with low libido. The thing is, the FDA has not approved a formulation for testosterone for women. So there's actually not even a product that we can give to them that is based and dosed for them. So because of that, we then have to use male formulations of testosterone, and and we have to then like cut the dose and like do a lot of like really specific things for it. And that's what the guidelines recommend, using the FDA approved options. Where the nuance and where the conversation and where the controversy comes in is the clinics and like practitioners that will say, oh, we can compound it, we can do pellets. We still don't know what that looks like. We just don't know the safety data for it. And so I understand why people are very up in arms about the pellets. I'm a person that doesn't believe in doing pellets for every single person. Like one of the things, like, because one of the it's again the marketing. So when people market pellets to you, they're telling you this is going to change your entire life, it's totally safe, all of the things. It's like, it could be, we don't know, we don't have the research, but there's also much cheaper options for you that are safer. So why don't you do that instead? And when you don't let people have those options, I think that's the issue.
Yeah.
Is that's where the snake oilsman type comes into play of, this is the only thing you can use, this is the best, this is the sexiest, this is, you're going to feel amazing, da da da. It's like, okay, well, let's back up. What does the research say? What does the data say? It actually doesn't say any of those things. So you can't guarantee or promise that to patients. And you have to let them know this is the risk. There is a higher risk. You're giving a big testosterone load, right? And so I don't do pellets for people that are like starting testosterone. Never do it. There are certain people that I will do a pellet for, but it's controversial. I know it's, well, all the things. But I do think this is where we can ask these nuanced questions of, this is research. We can actually answer these research questions instead of this kind of like infighting.
Right.
But you have to just be really truthful with patients and saying, this is what I can do, this is what I won't do. And this is why the pellet industry is a little snake oilsman-y, like
Got it.
you're promising all of these things without data to support it. And then you're not giving them other options that are more cost effective or more beneficial to them. That's the issue.
Okay.
Is saying, this is the only thing you can take and you have to pay me cash. Like that's where it gets skewy.
Okay, that makes a lot of sense. Thank you so much for explaining. So
Mm-hmm.
one thing also we didn't cover, if I am a person who is not comfortable using hormone therapy, even down in the vulva area, what are the other options? Because I know, for example, there's vaginal moisturizer, and then there's a certain osmolality that you need to look at, plus ingredients and things like that. So what else
Yeah.
can folks consider?
Yes. So again, yes, choice. And I do have these conversations with people of just saying, okay, I hear your fear. I absolutely hear it. In your fear, although it's not supported by data, I respect it. And there are options that are, that essentially treat the symptoms. They don't reverse it.
Okay.
That's the thing. Vaginal hormones completely cure the issue, versus these medications don't cure it. It just helps you with the symptomatic issues. So they don't really solve the issue of urinary tract infections and all of those things, but it helps with the dryness. So things like moisturizers can help with the dryness. They're also selective estrogen receptor modulators for people that have had positive breast cancer. That is also an option for people. So, you know, these aren't this isn't the getting down to the root of the issue, but these are things that are potentially at least giving you, again, getting you to a quality of life that you feel comfortable with.
I guess because you talk about how women eventually get to you, and obviously we want to give you as many patients as possible. Are all OBGYNs equipped if you say, please inspect my vulva? Should it be a NOMS OBGYN once we get to this age? Is that even sufficient? Like, what point
Uh,
do I come see someone like yourself, a urologist who understands my body?
and this is actually the thing that keeps me up at night. Is I'm a systems person, and if we look at the data, the access is just poor. It's not good. And I have to think about that as to why aren't people able to why is 50% of the population not getting optimal care? Like, what is going on? And one big reason for this is the lack of education, the lack of formalized education on vulvar health. Like I said, the field of gynecology and OB-GYN, it was actually used to be two specialties. So beforehand, it was OB, like you had to do your full obstetrics residency and all of those things. And then beforehand, you were a guy, or you were a general surgeon, and then you did a additional training in gynecology. So two very different specialties. They then combined them and didn't extend the training. So you now have literally two different whole training programs, and then just a short period of time. A lot of the time, vulvar health gets not taught well. If we look at the medical student side of things, the residency side of things, even the fellowship side of things, we're actually doing a survey to look at this, actually specifically ask these questions. There have been surveys looking at this in the past in a certain way. But yeah, the education piece is just not there. And that's us, again, the medical community not doing the right thing for our patients. And then, so that I sit with that, because even after the Let's Talk Menopause, we're sitting in a room in New York City. It's like, people that have access. And I, like, almost, my heart kind of broke because we got you all riled up to, like, go and want the care that you deserve. And I had to actually at the end be like, I'm so sorry, you might actually have a really hard
Yeah,
time. Like,
exactly.
you're going to actually have a really tough time. And it just, like, breaks my heart. And so, yeah, the best places to start are either NAMS trained specialist or sexual medicine specialist.
Okay.
So, I'm what I would call a sexual medicine specialist. I just came about it through the field of urology, but there are also sexual medicine specialists that are internal medicine, that are gynecology. So we have a specific focus in sexual medicine and overall sexual health, which happens to be bladder health and all these other good things. My ultimate vision is I want to shake things up in medicine to the point of forcing the American Medical Association, who is in charge of the curriculum for medical schools, to actually include vulvar anatomy in our training. And, like, when we go to medical school, how do we do a vulvar exam? They don't teach us this in medical school. We also don't really learn it in residency even. And I had to take then specialized training. And so we're literally ignoring a whole body part. And that we're being trained to do that. And that's an issue. I will not stop screaming this, because it wasn't until my fellowship when I learned how to do an actual vulvar exam. I went through medical school. I went through a really great urology training program where we treated women and prolapse and all of these things, and we're in the vulva. And I still didn't learn how to do an exam that actually examined the entire vulva. And, I work with gynecology residents and fellows, and they still don't know either. And it's like, there's an issue, and the call is coming from the inside the house. It's us as doctors. And the only reason I get to stand on this soapbox is because I get to treat men and I get to see what their quality of life is. And I love that. And I want that exact thing for my female patients too. I just want everyone to have access.
Yes.
That's really it. Access and ease, and instead of medical gaslighting and suffering.
Wow. I never realized just how truly unique of a position you're in. It is true, like you seeing the men and the women. And even in the conference, you all said really the clitoris and the penis are the same thing. We're just not looking at things properly. And so it's just even more clear what a unique position you're in. So I really appreciate you making time. So takeaways for clinicians and for the women struggling.
Vaginal hormones are vital. They are life saving, they are quality of life giving, they are safe, they are effective. We need to be doing better and more proactive. On the patient side of assessing your vulva and taking ownership of your vulvar health, and then on the physician side of educating ourselves, feeling comfortable, and being proactive in prevention instead of us getting into this trap of, oh, now this patient has recurrent UTIs and now we don't know what to do. It's like, well, we could have prevented all of this
Right.
if we were doing our jobs correctly.
Okay. Thank you. Wow. Truly, thank you.
Yeah, no, thank you for this platform. This is actually how people learn, right? And as a researcher, I'm really big into science communication. Like I can write all of these papers, I can do all these things that I think is moving the needle forward. But if my patients don't know, or the people don't know that they can have access to these things, what's the point?
Yep.
So speaking truth to power and like actually doing these things really matters. So thank you so much for this
Absolutely.
platform.
Thank you. Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find the link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.